Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome back to the Concussion Corner Podcast, where we bring you the voices shaping the future of concussion care. My name is Dr. Jessica Schwartz, and today's guest is someone whose work has transformed how we understand the next role in post-concussion symptoms. Joining us from Australia is Dr. Julia Treleaven, a physiotherapist researcher and global authority on cervicogenic contributions to dizziness, sensorimotor dysfunction, and chronic post-traumatic symptoms. In this episode, we'll explore how subtle disruptions in cervical spine control can drive persistent dizziness, blurred vision, and postural instability. Whether you're a physio, OT, AT, neuropsychologist, or physician, this conversation will sharpen your clinical lens and elevate your patient outcomes. Welcome to the Teach One, Serve Many community. Let's begin. Welcome, Dr. Treleaven.
Thank you for having me, Jess.
I'm so happy to have you back on. It's been a while. The last time you were on the podcast was 2018. We've had a pandemic, formed a school, and a few other things going on in the world. So I'm so happy to have you back on.
Yeah, happy to be here.
You know, and I'm so excited to have you on, really to speak to all healthcare providers, to really push this information out about the cervical spine and concussion. And I think it's been so misunderstood for so many years, whether it's the cervical spine or the oculomotor system or the vestibular system. And it's been such a blessing to be able to learn from you, to see kind of how all things are interacting, really just from you as a professor. So I've learned a ton, and I'm so happy to get this information out to the world.
Oh, thank you.
So I want to start with kind of one of a softball pitch for you, but I really want to make sure we get this information out to healthcare providers. So can you walk us through how the cervical spine contributes to sensorimotor control and what changes when it's injured?
So basically, the sensorimotor system needs information from the vestibular system, the visual system, and the proprioception of the whole body. But the neck is really important because it has a whole pile of muscle spindles, much, particularly in those suboccipital muscles, much more than any other area. It has reflex connections to the vestibular system and the visual system, and it has unique connections, particularly in the superior colliculus, which is thought to be the center for eye-head coordination. So it's really set up to provide that information. And so then that information gets integrated, and then that all helps to control postural stability and head movement control. So if information from the cervical spine is incorrect, which can happen from any kind of injury, even just, muscles changing function, pain, lots of things can change afferent activity, then that can influence what the information going in. And then people can get symptoms like dizziness, visual disturbances, but they can also have problems with head and eye movement control and postural stability due to that sort of poor afferent input from the neck.
When I'm teaching and lecturing, one of the things that I get, the most common questions I get from a physio is, Jess, I've treated the cervical spine and I'm 80% there, but I can't figure out the rest. And I also see the inverse when we're not speaking with physios, when we're talking to our colleagues across the aisle, and they haven't looked at the neck at all. So it's so interesting to kind of see how the interplay of what people know and what can be treated. So it's been such it's really an honor to kind of learn from you and from Dr. Kapoor and from Dr. Bliss and Dr. Master and Dr. Letty, and really just seeing how everyone's putting it together. But again, really incorporating the cervical spine, the oculomotor system, and the vestibular system, and really how we're making sure that we're addressing the physical somatic areas of concussion evaluation and treatment, but really how they all have an interplay together. So it's just been fantastic. In terms of the superior colliculus, can you kind of elaborate there just a little bit more? Just I'm an anatomy nerd, and I know a lot of folks that listen to us are as well.
So basically, it's an area in the brain that's thought to be basically the center for eye-head coordination. And so the cervical afferents have direct connections to there, along with obviously the visual system. So, no other proprioceptors in the body have that connection to the superior colliculus. So that's why I think that, it demonstrates the neck its importance in sensorimotor control.
And can you also touch on why the CO to C3 afferents are so important as well with the upper cervical spine in particular?
Yeah, so I think, definitely with respect to pain input, so that all of those areas go to the cervicotrigeminal nucleus, and so that can affect pain, and so then you can get the neck causing headache and headache causing neck pain as well. And so that makes it really murky to deal with. But those suboccipital muscles have really high percentages of muscle spindles. So, for example, your inferior oblique's got about 242 muscle spindles per gram of muscle, whereas your butt's got one. So, they're there for a reason. And they're probably very unique, highly functional proprioceptors, and that's what their function is.
Can you comment on gaze stabilization and postural reflexes and how that's correlated with the cervical spine?
Yeah, so we have the cervical ocular reflex, which is sort of seen like the baby sister of the vestibular ocular reflex, but it certainly does help and contributes to that gaze stability, particularly if your vestibular ocular reflex has been inhibited or reduced. The cervical ocular reflex can actually upregulate to help with that a little bit. But certainly, when we're moving at a more slower pace, the cervical ocular reflex can be helping to provide that gaze stability as well. So, yeah, I think the neck is really important in that function.
Yeah, and it's been so interesting to me to learn about the afferents and, the cervical spine and the output of, kind of what makes us function as human. And is often so missed when other healthcare providers that don't specialize in the cervical spine may not understand some of the subjectives that the patients are providing them. And then the cervical spine is missed. In that light, what are some of the most common clinical errors or missed opportunities you see when the neck is not addressed in concussion rehab? And again, this is in a space to always build up our interdisciplinary colleagues, but they may not be as well versed in the cervical spine as you are.
Yeah, so I think if particularly the sensorimotor side of things, so if people are, patients are complaining of some unsteadiness and some visual disturbances like blurred vision and things like that, that can be coming from the cervical spine. And sometimes treating the vestibular system doesn't particularly work for those patients. And often it increases their pain, and then that sort of increases that vicious cycle because, pain inhibits the cervical afferents and, so it's going around and around. So I think that's where sometimes, it's missed. And if you're not addressing, and to address the neck, we need to sort of treat the neck, what's causing the poor afferent input. So we might need to improve muscle function and improve joint movement and those sort of things. And then we also need to add that sort of tailored cervical related sensorimotor control exercises so that we've got the both. And so people might say, oh, well, if I'm doing vestibular treatment, isn't that like cervical sensorimotor? And yes, it kind of is a little bit, but there are some nuances. But I think we also need to be treating the underlying cause of the poor afferent input as well, so that when stopping that vicious cycle.
Indeed. And in terms of clinical signs that should raise suspicion when the cervical spine is involved, contributing to patients' dizziness or balance issues post-concussion, just want to make sure that we're reminding that we have, top down and bottom up, to consider with the central and peripheral systems with concussion. What are you seeing in terms of clinical signs that should raise suspicion that the cervical spine is involved?
Yeah, so from a patient reports, they would report more like an unsteadiness, not usually vertigo or true spinning. That they might report blurred vision, but not things like double vision and those sorts of things. And they might report that sort of feeling of clumsiness kind of thing, needing to turn the light on when they are walking and having difficulty in the dark and those sorts of things. And then they might report that their symptoms are more aggravated by things like sustained positioning or movements of the neck, those sorts of things. So things that would normally aggravate neck pain are the things that are aggravating those other sort of symptoms that are commonly related to concussion.
Now, a word from our sponsor. Did you know that sport helmets are rated on a 5-star system similar to cars? And the safest helmets have nothing to do with price, brand, or availability? Since 2011, Virginia Tech researchers have been providing unbiased helmet ratings that allow consumers to make informed decisions when purchasing helmets. The helmet ratings are the culmination of over a decade of research identifying which helmets best reduce concussion risk. This work is done as part of Virginia Tech's service mission and is 100% independent of any funding or influence from helmet manufacturers. Our mission at Concussion Corner is to expose you, the listener, to trusted spaces in the concussion arena that translate to clinic next day. Please visit the Virginia Tech Helmet Lab website in our show notes or at bit.ly/Virginia Tech Helmets and spread the word to aid in lowering concussion risk in your community. Thank you for tuning in, and let's begin the show.
I actually see the opposite, because when I see patients, they've often seen multiple providers after that have kind of mismanaged or just haven't been able to put the pieces together. Again, I always say with Concussion Corner and the Academy is that we want to make the complex uncomplicated. And unfortunately, when our healthcare system, at least in the States where I treat, I'm in New York, they may see one provider that's not related to another provider. So there's this lack of collective competence when we might have these, independent, collectively competent folks. So what I see is that we've addressed potentially things like the ocular motor system or like the vestibular system, but then the neck is completely actually not looked at whatsoever. And then you kind of have these, longer 2, 3, 4, 5, 6 months, and then they seek treatment for the cervical spine. So what are you seeing in terms of the differential in patient outcomes with, folks that get treated early and acutely, and then folks that may have a persistent whiplash or, persistent cervical spine and concussion symptoms, 3 to 6 months out? What are you seeing in terms of the patient presentation and also the patient experience with the healthcare systems that you're working with in Australia?
Yeah, so, certainly getting the neck treated earlier seems to have a better outcome. And I think there was a study in New Zealand where they looked retrospectively at, patients, and they found that people who had, when they addressed things like BPPV and the cervical spine early on, within about 3 weeks, they had a much better outcome. So I think that's important. And also, even if somebody has a significant vestibular problem, then if they have a problem with their neck, often they can't do the rehab that's involved. So I think that's important that we can see the neck and address it early. It is difficult sometimes, particularly in those people who've had a significant injury and people who have a lot of other impairments associated with their whiplash. And so they will take longer. Certainly seeing them earlier, being able to identify the different areas and where to address, I think is the key, really.
Just thinking, are there any patient profiles or histories that immediately make you consider the neck as a primary issue that may have been missed by another provider as soon as you get to them? Do you see anything, even objectively with your eyes, like are they rotated, are they fear avoidant, are they, moving on block? Like what are you seeing immediately? It's kind of like the physio walking in an airport. We can never not analyze someone's gait. Are you seeing anything that just common things that are sticking out that are immediately missed, either subjectively or objectively in your world?
Yeah, I think, when they're walking and they're reducing head motion, so they're really not using their head and not turning full range of movement, they are going a little bit en bloc because they've learned to try not to use that. That still could be vestibular though, so I think that's the problem. It's difficult to just, you have to do a really good skilled examination. One thing is not going to add it up, and there's going to be lots of people who are going to have all impairments, all systems impaired, and it's trying to work out, is the neck involved? How much is it involved? Is it a lot? Is it a little bit? Is it being driven by something else? So it could be the visual system that's driving the neck problem, and so you can treat the neck for as long as you like, but if you don't sort the visual system out, it's just going to keep driving that neck pain.
Indeed. You've been doing this a while. You've been in the research realm since 2000 in the cervical spine area. So you've devoted so much of your career, and it's so important. I was just at the Concussion and Sport Group midterm conference in Milwaukee, which was attached to the Sport Neuropsych Society conference. So I was in Milwaukee for 3 days and 2 nights, and it was kind of like being in the room where it happened. If you've ever watched Hamilton, either on Disney Plus or if you've been to Broadway here in New York. But everybody was in that room, from South Africa to Australia, New Zealand. We had folks from 18 countries, and there were about 200 folks at that conference. And, at the end of the day, Mike McRae made a statement, and it was so apropos, and I wanted to see how this would correlate with the cervical spine and the whiplash research that you've been doing for your career. And he said, we just have more data, and we've been asking the same and slightly updated questions for the last 3 decades. And they're all the same questions. We just have more data now, and we still have so much to look into and find out. Where are you in the cervical spine world? What's different in the last 25 years, and what's the same? And then where do you hope, we can kind of traverse, in the next 5 and 10 years?
Yeah, so I think particularly in the whiplash space, early in the piece, there was a lot of work showing what impairments people had, so all these different things across the biopsychosocial realm. But unfortunately, management has, RCTs. I don't think there's been an RCT in physiotherapy since sort of something like 2015. And the reason for that was because a lot of them, they spent a lot of money, and it kind of showed that, it didn't make a huge amount of difference what you did to people. But I think that's the problem with grouping everyone. So nobody's the same. We can't group people together. There's certainly been some nice work coming out in physios delivering stress inoculation, so help, alongside the manual therapy, the exercise, but also helping patients manage their stress as well has been an area going forward in whiplash. And then I think, there's a lot more recognition of the neck involvement in concussion. And so that's great. But again, we don't have a lot on the treatment for that, and how people respond with treatment. So I think that's where we're heading. And we're probably getting more data to confirm and say that this is really happening. But now we have to work on, when's the best time to intervene? How should we intervene? And that sort of thing.
Yeah, we have our last 4 minutes here, but, just thinking about what you said there for the cervical spine section, I'm just thinking about concussion and the inclusion of even just social determinants of health in the past few years. We're using questionnaires just to really kind of understand. And, I've been preaching this for 10 or 15 years of, you have to understand where the patient's at when they're coming into your clinic or you're going into their home or office if you're doing home treatments. And, again, if the patient is going to be losing their home or their job or their health insurance in this country, we don't have public health, are they going to really be able to accept your treatment? And I think that's such an important thing to talk about when you were talking about with stress inoculation and just stress and things like that. And then also fatigue. I mean, the fatigability of those cervical spine, those intrinsic muscles. It's so interesting. We were just at a Liberty game the other day and it was like, okay, or even like the fifth set, tie break at the French Open. It's like, you really have to train. Like, how do you train for that, right? You really have to run a marathon, get so fatigued cognitively and physically, and then go serve 120 miles per hour and play in the heat. And it's the same thing with kind of training folks with concussion, is that we find that they're either their neurofatigue or their fatigability physically, cognitively, kind of from the whole 360 depends on where you get them kind of in the day for your treatment session. So it's just been, are you guys using any social determinants of health questionnaires out in Australia?
In terms of nothing specific for, I guess, from social determinants, but we certainly use, sort of behavioural type questionnaires. So things like anxiety, post-traumatic stress type symptoms, those sorts of things.
Fantastic. And then, as we wrap up here, we've had the good fortune of adding you to our part 2 of concussion, the patient rehabilitation journey at Concussion Corner Academy. And I just wanted to kind of connect to, as we wrap up here, kind of what stood out to you about the kinds of questions that our students are asking. They're clinicians first, and they're coming to learn from literally the world's best. And what was there any kind of bi-directional learning from you as the students are asking you questions? Because obviously you've imparted so much on them with your knowledge. And what stood kind of out to you there with our students?
Yeah, I think it was just such a high level of clinical reasoning, and they were really absorbing all the information and starting to go, oh, I've got this patient that I had, and I'm thinking now I really could have done this. And so I think it was that them really being able to see in their patients how things they could change. And then some of the questions were really high level, like, made me think about what that potentially could mean. So it's been really good. And, because those people are on the trenches, they've seen lots and lots of concussion patients. I've seen, some concussion patients, but, those people are sort of, often that's been their bread and butter for the last, 10, 20 years. So yeah, really good to be involved.
Yeah, we've had folks 0 to 38 years out. And just to clarify, folks that are meeting Dr. Treleaven, we're actually through our first part of our 12-week programming. So when they're really coming in, they're pretty robust in their knowledge, so they can really ask high-level questions. So it was very cool as a program director to see the interaction and these high-level questions come out that are really pertaining to next-day knowledge translation clinically. And then finally, as an educator yourself, again, our number 2 students, from country-wise, we've been in 6 countries and 39 states and across 8 professions, interdisciplinary so far. As an educator yourself, how important do you feel these kinds of immersive interdisciplinary educational experiences are for advancing concussion care globally?
Yeah, I think it's so important, Jess. You have to understand the other systems well enough so that you can, even if you, can't treat you don't know everything about the vestibular system, as long as you can understand how it all links together so that then you can work out the best treatment, what needs to be treated first, that sort of thing, and then being able to know when to refer out and when you need more help. So I think this, having that team together is fabulous, because people really realize the way that each of those can work together. And so I think it's important. We're not just sort of isolating one area, because I think if you do that, then you're not going to have as good an effect in concussion. You need to be able to understand the whole lot.
Yeah, and it's fantastic. And just thank you for being a part of it. I just want to make sure that we're imparting, here's what I can do as a physio, here's what you can do as a physician, an OT, an athletic trainer, a speech pathologist, and so on and so forth. And here's how we can treat together. Again, Dr. Treleaven, will there be a part 2 of this? We're so glad that you're back on for part 1. And just thank you so much for coming on and representing your patients from all the way from the clinic to the research level. So thank you again.
Thanks for having me, Jess.
Thank you so much for joining today on the Concussion Corner podcast. We hope you found today's conversation with Dr. Julia Treleaven as enlightening and clinically actionable as we did. If you're ready to take your concussion care to the next level, we'd love to invite you to join us for our fall 2025 cohort of Concussion: The Patient Rehabilitation Journey, Part 1 and 2, where you can join our on-demand programming anytime between January and September, and then join our live sessions with all of our faculty September to December 2025. You'll not only dive deeper into the evidence and rehab strategies we touched on today, but you'll also have the opportunity to meet Dr. Treleaven live alongside our faculty of world-class clinician scientists, combined with weekly office hours and one-on-one coaching. Enrollment for our 2 12-week courses are now open. Visit us at concussioncorner.org to learn more and reserve your seat. Let's change concussion patient outcomes together worldwide, one clinician, one clinic, one hospital, and one community at a time. Until next time, stay curious, stay kind, and keep leading with compassion. Take care.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.